Welcome to RetinUp. I'm Scott Krzywonos.
And I'm John Kitchens.
John, today is our mailbag episode. We had 3 listeners send in questions. They want your thoughts and your feedback. Shall we?
Let's do it.
All right. Our first question.
Well, this is Dr. Jed Assam at VRA Vision, a retina practice in Sioux Falls, South Dakota. I am calling in to ask a question about how or if any retina practices that you're aware of are looking at cash pay model diversification in an era of declining reimbursement from the existing payer model of insurance-based care.
Yeah. So, Jed, it's a really interesting question. You know, our primary care colleagues, and I don't mean general ophthalmologists, I mean primary care doctors, have actually been doing this now for more than a decade. Concierge Retina, or concierge care, and actually is a retina specialist in California who gave a talk at the Atlanta Business of Retina meeting. Her name is Vivian Kim, about concierge retina. And it's interesting because in a lot of ways, if you're in the right location, concierge retina actually probably could work. I mean, for busy practices in bigger cities that have affluent patients who don't want to wait, I could imagine a carve out where you could provide your cell phone number for patients, direct contact, limited numbers of appointments, no waiting, priority parking. I mean, because our patients come back so often to see us, I think there are some VIP perks that could potentially be offered. Now, in Kentucky, I can tell you that probably not a great opportunity to do it. But if you're in New York and LA, any one of those type places, I think that concierge retina or a cash pay option actually could be great. And I don't know if Vivian's going to speak about this at the next Business of Retina meeting, which is coming up here in just a couple of weeks, or possibly at the Academy. But I sure would be interested to find out if there's anybody else out there who's participating. So I'll throw it back to our listeners, Scott, and say if you are doing any kind of concierge retina or providing any cash pay services that are unique, shoot us an email, give us a call. Be fantastic to find out and share with our listeners. Heck, we might even have you on as a guest to talk about how you set this up.
If you're out there, info@retinup.com. That's our email address. So yeah, shoot us an email or shoot us a voice memo.
The other place, Scott, that I think cash pay is actually becoming more mainstream is with photobiomodulation. And we know we had the Valeda PBM device approved last year. Alcon acquired access to that device. And so you've got Alcon's kind of muscle behind it. It right now, for the most part, is a cash pay situation. And we've got one in our clinic. And once again, in Kentucky, maybe not the best market for a cash pay situation, but I do think in some locations, it actually has been a profit generator for some practices. So I think it's different for us to think about ever taking cash pay because we're so vested in Medicare and insured patients, Medicaid, and medical treatment of retinal conditions. But it certainly would enhance the sustainability of what we do.
I remember being at a meeting years ago and there was, I forget exactly which company was putting it on, but there were cataract and refractive surgeons and retina surgeons sitting on the same panel. And the question of cash pay options came up and the retina specialists looked very uncomfortable. This was maybe 2018, and the cataract refractive guys felt perfectly comfortable talking about this. This is one of their models. Do you get the sense that Valeda is the introduction to a cash pay model for a lot of doctors? And what do those growing pains look like as far as cash pay goes? Not just from a ethical standpoint or a comfort with the patient, but also the logistics of actually collecting cash and tracking cash and having that whole new line on the ledger.
Yeah, it certainly seems to be. And the interesting thing is going to be in a couple of years, insurance will start to cover photobiomodulation, and then it will shift it out of that cash pay. I think
Okay.
what we need, Scott, is that next follow-up that's going to come. And might it be something like laser for vitreous floaters. I mean, we already know that people have done laser for floaters, and it's quasi-successful for the right patient, the right situation. And that, I believe, has been mostly a cash pay model, but it's just not a mainstream sort of thing. If there ever was an approved laser that was highly effective for vitreous opacities, I think that would potentially lend itself to a cash pay model, which could be very, very interesting.
So this question in particular was about diversification, using cash pay as a means of diversifying in an era of uncertain reimbursement or declining reimbursement. Is there a model where Friday is the cash pay patient, or is there a model where the all the cash pay patients are after 2 p.m.? Like, how do you envision the diversification actually looking in practice?
Yeah, I think you're right, Scott. I think it would have to be a set aside day where you have very limited number of patient appointments. Patients get extra time. They don't feel rushed, but they also don't have to wait. I can't imagine trying to mix in cash pay patients or concierge patients in with your regular clinic patients because those patients, you have them in their waiting room all the time and they see one patient go back before them and they get upset. And
Right.
so I can only imagine how you would try to justify that to patients. But certainly if you had a half a day or a day every couple of weeks that was specifically limited number of appointments, and once again, I think those patients would have to have unique access. I know in the primary care world, they have their doctor's phone number, they get calls at home and
Uh-huh.
those sorts of things. I could see that being something that could be highly successful in the right location.
Yeah, you mentioned the right location. This color's in Sioux Falls, South Dakota, pretty rural area. I'm sure Sioux Falls is, a lovely town, but it ain't Chicago. What do you think that sweet spot is? Is it major metropolitan area? Is it affluent suburb of major metropolitan area? Is it something else?
Yeah, I think it would have to be that major metropolitan area. I think you're talking about a place like San Francisco, LA, a New York City, Chicago,
Okay.
someplace where, and you'd have to be in the right location in the right part of town and whatnot. The only other thing that I've heard people, charging cash pay is for in-office surgery. And in-office surgery has been
Oh, okay.
something where people will actually do cash pay situations in a handful of locations and a handful of places. And it's a little bit tricky because surgery is such a high priced, sort of situation. So it's tougher for patients to pay, $10 or $15,000 to be able to have a surgery someplace that's not a surgery center. And most surgeries are going to be covered by their insurance. So that's a little bit of a deeper dive and I think a little bigger ask.
All right, let's get on to our next question.
Hey, John, this is Deepak Sambara out of Wisconsin. This is a crystal ball question for you. With all of these new emerging therapies that may be set to hit the market in the next few years, assuming that these phase 3 readouts are positive, where do you see these agents in our clinical armamentarium? Are these first line, second line? More importantly, what do you think the payers are going to do about it? Is 99-year-old Meemaw going to be able to start with gene therapy, for example? Hope you guys are doing well.
Well, thanks for the question, Deepak. And I love the fact that you take care of 99-year-old Meemaws as well. I love grandmas and grandpas and patients who come back routinely for their injections. Yeah, it's probably the biggest question. Right now we're at a real flux when we have managed Medicare patients and managed Medicare systems having declining reimbursements. This past year, the U.S. government kept their rates flat when they were reimbursing, United Healthcare and Anthem and whatnot. And so it's put a little bit more pressure on them to maintain their profitability. We've had a few pull out from our region as far as managed Medicare. And so I think it's going to get tougher and tougher. I think we're going to see more tiered therapy. We're going to have more Avastin first policies, longer times on Avastin to try and maintain some sort of cost control because a lot of these companies want to maintain a profitability. Now, for traditional Medicare, it's going to be a little bit of a different animal, but those patients are actually going to have a supplemental insurance to cover that additional 20%. Any medication, tyrosine kinase inhibitors, gene therapies, anything that's going to act longer and give patients better, longer disease control is going to be priced at a higher amount than our current monthly injections. And they're going to amortize it. And they're going to say, all right, if a year's worth of Eylea HD is going to be $15,000 and our drug last 9 months, we're going to basically charge $11,000, maybe a little bit of a value proposition for insurance companies. But they're not going to give these companies and insurances a big break because they still have to maintain profitability. So the rub is going to be what we see with drugs like Iluvien or like Susvimo, the surgically implanted sustained delivery device is that you're going to have this larger upfront cost, for this treatment. So it might be $6,000 or $8,000 for a tyrosine kinase inhibitor injection, and the insurance might cover 80%, but is the patient going to be able to pay for the 20%? Is Good Days going to be around to be able to still pay for that, or a patient assistance program? So it's going to be tricky to see. And gene therapy, Deepak, is on a whole different level as far as the cost to create gene therapy. Gene therapy might potentially be a one and done thing. So how now do you price that in a situation where you create the eye becomes your anti-VEGF factory and you might not need another injection ever? Is that going to be $35,000? Is it going to be $50,000?
Well, and to his point, if it's in a 99-year-old patient versus a 70-year-old patient, that's a very different runway.
And Scott, what these insurance companies do is that they take into account the fact that the patient may switch insurances. And so they're not going to be interested in paying for a treatment that's going to take care of a patient when they switch from Anthem to Humana. Anthem doesn't want to pay for a treatment that patient ends up on Humana insurance in 2 years, and they've put forth $50,000 to control their wet macular degeneration. So it's going to be interesting to see how this plays out. I certainly think we're going to have great therapeutic options for our patients, but the price point is going to have to present some sort of value to society and value to the insurance company for them to be able to jump on board. Case in point is Incelto. Incelto is a really novel treatment for macular telangiectasia. It slows down the disease progression by 50%. The price point is $250,000, and
some places just aren't using it, right? Because they're afraid that they're not going to get reimbursed.
Yeah, we've got 5 or 6 patients that are very interested in having this done, and our surgery center has said we are worried that we're not going to get reimbursed for this. And so Neurotech that makes Incelto has a couple of different approaches that they can utilize, including their own specialty pharmacy to try and get this covered for patients. It is being done more and more frequently. I think they're up to about 100 implants that have been done so far in the U.S., which is pretty impressive given that price point. But it's a big ask. It's a big ask for a surgery center to front that cost.
Where does step therapy play in all this? You mentioned earlier, right, like having to stick on Avastin for a long time. But what about, let's take wet AMD as an example. Let's take a TKI as an example. That's not quite an anti-VEGF, but it still has hopefully the same therapeutic effect. Is it going to be the case where there might be step therapy using a different technology, i.e. you still have to go on Avastin and fail on Avastin before you can get to a non-anti-VEGF option for the same disease? Or am I overthinking this? Is it actually just as simple as use the cheapest option?
No, I mean, insurance is always going to want us to use the cheapest option, but eventually you're going to have the ability to use something better for your patients or stronger for your patients. Now tyrosine kinase inhibitors are very interesting, especially the ocular therapeutics TKI. As we know, the SOL-1 study just came out, and that was a superiority study. Now, it was a very different study, but and not the kind of study that we traditionally are used to seeing, where it's compared to every other month of aflibercept. But it might get them a label that has in it superiority over anti-VEGF therapy.
Yeah, and then what do you do when it comes to step therapy?
How does the insurance company prioritize this? And I often ask, how does the insurance company justify using a non-FDA approved or off-label treatment like bevacizumab first? And it's because they have this compendium that they go to. And the compendium is not only made up of FDA-approved products and their labeling and whatnot, but it's also publications, practical advice and whatnot. And they go to that to kind of say, hey, this is where we're going to put this tiered therapy. So it'll be interesting to see where the TKIs end up in this whole dynamic of things.
I mean, it's not that shocking that they would require Avastin to be used first from a scientific perspective. I mean, there's a huge body of evidence that says it is a safe and effective drug. Is it the Most effective drug, okay, maybe not in some patients, but nevertheless, like I see how they get there.
Yeah, I mean, and we have studies, and this is where I love the DRCR network
Yeah.
because they actually did a study that looked at if you started patients on Avastin but had a very low threshold for switching them to Eylea, could you go ahead and use Avastin first for those patients that Avastin did work for, and then for the patients that needed it, switch them over to Eylea, and certainly their study showed yes, you could, and you didn't lose anything by that. I think it was the Protocol AC study.
Yeah, it was some protocol. I can never remember
Yeah.
which one's which.
Yeah, exactly, and it's super helpful to know that by the end of that study, more than 70% of the patients actually ended up switched over to Eylea. So you could see that there were a significant number of patients that by the study switching protocol were considered treatment failures on Avastin. But it's nice to have that data there to show you can start with a cheaper option and not lose anything.
All right, let's take a quick break. When we get back, we've got one more question in the mailbag. Stick with us. Hey there, listeners. If you are subscribed to the show, thank you. If you're not subscribed, do so on your podcast platform. Alternatively, you can sign up for our newsletter where we will let you know when we have a new episode dropping. I promise we will not spam you. We are only telling you when we have a new episode. You can do that by visiting our website, retinup.com. RETINUP.com. All right, thanks for sticking with us. Let's get to question 3.
Hey, John. This is Priya Vakaria from Retina Vitreous Associates of Florida in Tampa Bay. I have a question for you, and it's one that I struggle with a lot. In Retina, we have great imaging devices and surgical technologies, and they keep getting better and better, but they're also getting more expensive. And the problem is that our reimbursements are declining. So, how are practices realistically expected to adopt new technologies when reimbursement continues to tighten?
Boy, Priya, yeah, I mean, it's funny, Scott, that all these questions in our mailbag have been about issues with reimbursement, declining reimbursement, new technologies that are going to cost more money. It all comes down to, can we afford to implement these things?
Yeah, man, no money, no mission, right? You need to be
I
funded.
mean, you got to run a good business to stay in business. So, but really great question, Priya. And I think, the biggest place that we're seeing a declining reimbursements this year, at least, is going to be in the operating room. We've seen 11% cuts across the board for most of our major vitreoretinal surgical procedures. Our cataract colleagues have also taken a hit in the OR. So they offset that a little bit if they're doing premium IOLs, or a lot if they're doing premium IOLs. That's a good cash pay, generating surgery. But for us, an 11% decrease for our surgery centers makes it really tough. And tough when you have a quality machine like the Unity system that's just been released by Alcon. There's a definite premium price point there. You're going to have an increase in pack prices as well when you implement the Unity system. So it's a tough uphill climb. You're going to have more efficient surgeons. You're going to have equipment that makes you more efficient. And we actually did a time and motion study looking at the Unity system, showing that we had a 30% faster turnover, setup, and tear down with the Unity system. We had faster laser, faster surgery, but is it enough to offset the costs? And I think that's yet to be seen. Probably depends on your patient mix, or you're operating at a hospital or a surgery center, because there's differences in reimbursements there. The biggest question is how do we continue to implement new technology in our clinics, particularly OCT and imaging technology? And I think we might have hit a little bit of a glass ceiling with where we're at as far as our imaging technology. I mean, our OCT with the Zeiss Cirrus system, or the current, spectral domain systems,
Mm-hmm.
actually are quite good. They really help us resolve what we need to resolve. To go to the swept source imaging systems, probably not at this point, given their price point. Does OCT angiography really play a big role in what we're doing? We did, Scott, get an increase in reimbursement actually for OCTA.
Right.
Which is kind of a nice bump up, but do we really need it routinely for our patients? I haven't found that I need it in clinic. Our ultra wide field imaging system, and I love the Optos ultra wide field imaging system, is great, doing less fluorescein angiograms. So I think we might see a little bit of a stagnation when it comes to our imaging equipment and our imaging, evolution and revolution that we're having. But I do think we're gonna see a breakthrough when it comes to AI. I think we're gonna see
Oh, okay.
AI make us more efficient at following patients, recognizing treatment trends, knowing when to switch patients' treatment, giving us advice on just how to better care for patients that we've seen. AI is amazing in that it can assimilate so much information on patients, and it can look back and really give you not only the forest, but the trees and help you make better clinical decisions. But what AI won't do is it's not going to put a needle in the patient's eye, and it's not going to sit there and answer the patient's questions. We're just not there yet, and that's what takes us most of our time. So it might make us a little more efficient behind the scenes, but that forward-facing, patient-facing interaction is still going to be a rate-limiting step.
Is there, back to the imaging question for a second, it sounds then like the value proposition that would need to be demonstrated between one imaging modality or model and another is an efficiency unlock, right? Like you would need to be able to become a more efficient diagnostician. You'd have to become a more efficient practitioner. Does that seem right? Like if we've hit the ceiling on the quality of the image, then that seems like the only other area to grow or to get some sort of an unlock. Am I reading that right?
Yeah, absolutely, and that's also where I think AI can come in and help to give you that. It can once again look at multiple scans. Also, diagnosing and predicting how geographic atrophy is going to progress.
That
We
would
all
be huge. Yeah, that
struggle.
would be really big.
Oh, we really struggle with knowing who are the right patients to treat with GA, and then to demonstrate to patients like this is what you would have progressed on to if we hadn't treated you, to give them some sense of satisfaction with their treatments and whatnot. So I think if AI can really help us with RPE analysis and loss, photoreceptor preservation and whatnot, it would be huge. I know Ursula Schmidt-Erfurt is working on some AI algorithms to kind of help us better understand GA and the way that it progresses, and it can't get here soon enough.
Wait, so wouldn't that actually though make your clinical efficiency less efficient because now you're sitting down with the patient to explain to them what their anatomy would have looked like had they not intervened with, in this case, anti-complement therapy, but with some sort of therapy? Like, aren't you now spending more chair time? So actually AI is making you less efficient?
Well, it might. I mean, if you've got better visuals to show those patients, it might be able to increase that ability for patients to understand why they need to stick with therapy. And at the end of the day, if they stick with therapy and they have better adherence, that's going to be a better thing. I'd have to imagine that this AI, at least how it works now, you have to upload the images to the cloud. It has to be analyzed, and then it gives you back the information. So I think most of the patients that are currently being done with AI, you're uploading their previous images so that by the time they come in, the AI's kind of been able to grind through that and give you some answers, but you don't have it in real time. And then the billion-dollar question, trillion-dollar question for all AI is how do you make money off of it?
Yeah,
I mean,
right.
they can't just give this stuff away for free. How do you monetize that? And the government's not going to pay us more for using AI. So you're going to have to find some way to be able to afford the AI systems that are out there. Is it going to be a virtual scribe and
Mhm.
transcribe things? Is it going to generate more patients getting on GA therapy? And that's how you're going to justify it? I don't know. I don't think anybody has an idea around that in the AI community is how do you pay for all this?
Yeah, I think the ROI on AI usage is going to be very squishy, right? You're going to have to compare, I don't know, time points from, when you fully adopt AI to 3 years ago when you didn't have it at all, and control for changes of reimbursement and inflation and all those other things. We may just never have a really clear answer on it. Moving back to Priya's question for just a second, her real question was like, how are you realistically expected to adopt new technologies? Which I think another way of asking that is, how does a practice like, yours, for example, decide when it is time to adopt the new technology for the sake of not just efficiency and cost, but also elevating the quality of care?
Yeah, in 20 years of doing this, we've had a couple of evolutions of technology. And about once a decade, you have a new technology that comes around that you say, okay, we can't do what we do as well without this. When I first started, it was OCT. I mean, you really, in 2005, you quickly learned like, This allows me to see the retina better and track the macular changes better in patients than I can do at a slit lamp with a contact lens and whatnot. So
I truly don't know how you practiced before OCT.
Oh.
Like it seems like it made the field of retina what it is today. Full
Yeah,
stop.
I mean, well, we didn't have the treatment options, so that was
That's
at
true.
least one limiting factor. But the fact is, you put a lot of contact lenses on people's eyes, and I think you did a lot of guessing and hypothesizing that something looked better or worse than it did before. But yeah, I don't know how we practiced before OCT. The next was ultra wide field imaging and ultra wide field angiography, and that's been a real game changer. But that took a little bit longer. As you know, Optos introduced their system mainly into optometry clinics first, and they rapidly adopted it. And it took a little bit longer. It took the fluorescein angiography component of it to actually get it into the retina clinics. And now I feel like most retina practices have Optos ultra wide field imaging. It's a great way to do a screening examination on patients to look for tears, diagnose and measure tumors, diagnose and monitor diabetic retinopathy. So I haven't yet seen what that next thing is. I thought it might be OCT angiography. I don't think it is, Scott. I mean, the utility is just not there for OCTA at this point to make it that next big thing. So I don't think that next technology is out there. So what you end up doing is you kind of add as you need to add. So we'll have a clinic and we'll be using our OCT and our Optos imaging system in a clinic. When we get to capacity where we feel like we can justify getting a second OCT or a second Optos camera, we will do an ROI on it. And we would say, okay, will this make us more efficient? And will that efficiency increase our revenue? And then we'll go ahead and add a second camera or a second OCT scanner.
What about the OR? When do you decide that it's time to shell out the cash, have that CapEx to get some new equipment?
Yeah, so it's really interesting, and this differs across the board. If you're operating at a hospital, that capital cycle is completely different than at a surgery center, and it's a bit of herding cats, and everyone's competing. So in our surgery center, we've got cataract guys jockeying for new equipment. We have ENT doctors, GI doctors, ortho doctors. Everybody has their priorities for what they want with new equipment, and so I think it's seeing where you're at on the cycle. I mean, if you haven't had an update to your equipment in 5 or 6 years and everybody else has kind of been getting new things, you want to kind of talk to your OR managers and your surgery center and kind of say, hey, listen, we'd really love to have this new equipment. And then once again, the surgery center is going to do a look and say, is this going to increase our efficiency? How are we going to pay for this? How are we going to justify this? Do we need new equipment? For the Unity system with Alcon, one of the things that we found is that it looks like in our surgery center, because the vitreoretinal machine can be used by the cataract guys, we're going to be able to go from having 5 machines, 3 cataract machines, 2 vitreoretinal machines, down to 3 or 4 machines. And although the machines are going to cost more because we're going to have to trade in older machines and you're only going to get a fraction of what you paid for those towards the purchase for your new machines, but your service contract is going to lower because instead of paying for a service contract now for 5 machines, you might be paying for it for 3 machines.
Right.
And you amateurize that, the efficiencies and whatnot, and you try to figure out if it's going to be a break even or what your break even's going to be.
All right, that's it for our first mailbag. Thank you to those who submitted. We appreciate it. If you have a question that you would like John to answer, email a voice recording to info@retinup.com, and we'll put it in the mailbag for our next mailbag episode. Also, there's other ways to reach us. If you want to leave us a comment on YouTube, feel free to do so. We might engage with it in one of our upcoming episodes. If you want to hit us up on LinkedIn, you can find me or John, or you can comment on a post promoting this episode. And also sign up for our newsletter. Go to retinup.com. We will send you an email every time we have a new episode. We will not spam you. We're simply there to tell you to start listening. That's it. Thanks for now.